رح نبدأ الآن بالسيشن تبع الفارماسيتيكال كومبانيز. دكتور قيس بلبيسي، دكتور مروان حباب موجود، دكتور إياد عواد من فلسطين، دكتور عدنان، أنا رأيي كمان بدنا كمان طبيب يكون موجود معنا. من العراق مين بيحب؟ مش موجود الدكتور عدنان، مثله حيدري، تفضل.
يعطيكم العافية يا جماعة. يلا زي ما حكى الدكتور محمود، إن شاء الله المنسف ما يكون أثر كتير، بس صراحة هو ذكي. let's go ahead and start. راح نبلش مع الدكتور محمد الجعبري who's going to tell us about Entresto. Time is now. طبعا الدكتور محمد غني عن التعريف، من well known cardiologist في الأردن. احنا أصدقاء من أيام الطفولة، كنا بمدرسة مع بعض وقعدنا على زي ما بيقولوا مرتبة واحدة for 4 or 5 years at least، صح؟
طبعا منذ نعومة الأظافر. سبحان الله. سلام الله عليكم جميعا. طبعا يوم جمعة وبعد الصلاة ومنسف وهارت فيلير، الله بعين. طيب خلينا نبلش. هارت فيلير it's really not a simple disease, and I think heart failure, the malignancy of the heart is the heart failure. Heart failure is a progressive disease leading to decreased quality of life, increased hospitalization, and also increase the mortality. We have over 26 million people suffering from heart failure. Heart failure is also associated with high rate of hospitalization again and poor quality of life. Why? Because hospitalization once every year after initial diagnosis, atrial fibrillation, and higher basal metabolic, higher basal medical body mass index, and higher hemoglobin A1C with a low EGFR are strong predictors for heart failure hospitalization. That's why heart failure patients are suffering from poor quality of life. Also, populations aging and increase overall comorbidities prevalence are expected to increase the heart failure patients, and in the coming next 25 years it will increase up to 50% patients will be suffered from heart failure. What about the prognosis? All of us know that 1 year mortality for heart failure is almost 20%. And the 5-year mortality is almost 50%. Again, as I told you at the beginning, the malignancy of the heart is the heart failure, and even sometimes worse than the malignant. In male, as you see here in this slide, prostatic cancer are less prognosis than heart failure, and also breast cancer in women are less prognosis than heart failure. So with heart failure, with a 5-year survival rate is almost 50% mortality, as shown in these slides. So, can patients with heart failure wait? Heart failure patients cannot wait at all. So, with this disease and the progression of this disease, دائما احنا ما بنقدر نقول مريض الهارت failure is stable patients, because from time to time it will deteriorate of acute episodes, acute hospitalizations, and acute pulmonary edema. This disease and the progression of disease lead to this mortality. With each acute event, the myocardial injury lead to progressive left ventricular dysfunction and increase the mortality. So, I have a good medicine to improve the ejection fraction and to improve the heart failure hospitalization and the quality of life. So early initiation المرضى اللي بنبلشهم على بالذات اللي هم اللي عندهم new onset heart failure patients is the early initiation of medicine improving the left ventricular ejection fraction, the outcome will be better than delay in giving him the medicine. Why? Because ARNI is the first management and the first medicine that change and reshape the heart size. All of us know that in heart failure, the size of the heart will become more enlarged and the cardiac size and the volume increases. So that leads to decreased cardiac output and heart failure. The only medicine in heart failure can go and has the ability to reverse cardiac remodeling of the heart is the ARNI, especially in the new onset heart failure. As you see in this slide, the left ventricular ejection fraction arm and the left ventricular end diastolic volume index and the left ventricular end systolic volume index and the left atrium and the EA ratio, with using this medicine, there is improvement in the left ventricular ejection fraction by mean almost plus 9.4, and the new onset heart failure is almost up to 12.8. And what about the dimensions, the left ventricular end diastolic and the systolic index? It will decrease. So the heart failure per se cause increase in the cardiac chamber, and we have a medicine that improvement in the left ventricular ejection fraction and decrease the sizes of the left ventricular end diastolic volume index and the left ventricular end systolic index, and also the EA ratio. And this is very important in heart failure, especially with the preserved ejection fraction. Again, here the slides show the reverse cardiac remodeling with ARNI and the mechanistic explanation of how this medicine improve this patient's outcome. You see after 6 months and 12 months, how come this medicine increase the left ventricular ejection fraction by %, and how it will decrease in the volume of left ventricular end diastolic volume after 6 and 12 months, and also in the decrease in the filling ratio after 6 and 12 months. And this slide show how important and how mechanistic explanations for these medicines. Here in this slide, this is very important slide, show in subgroup analysis in pioneer heart failure, وكلكم عارفينها, how ARNI has consistently beneficial effect on the newly diagnosed heart failure with reduced ejection fraction in comparison with ramipril. And overall, there are 34% de novo in pioneer heart failure, and how ARNI show the superior reduction in the heart failure hospitalization and cardiovascular death. Also here, we have two arms. We have patients starting from enalapril and then switched to the ARNI, and another patients are at the beginning, they are started with the ARNI. We see in the arm that the patient who are started with the ARNI any delay in initiation of these medicine lead to higher outcome. And all the patient who started with ARNI immediately has a better prognosis and better outcome over the 12 weeks. Also, ARNI significantly reduce the number of sudden cardiac death compared by enalapril by 20%. So, the right agent is the ARNI, and all of us know is valsartan alone is okay? Well, it should be combined. That's why neprilysin inhibition is a must. يعني ما بنقول والله valsartan فقط هو اللي بيقدر يعمل reverse cardiac remodeling. Why? Because this is very important slide, show how there is a reverse cardiac remodeling and the mechanism of how ARNI can affect on the heart failure. All of us know we have two groups. We have a valsartan and we have a neprilysin inhibition. All of us know valsartan is block the AT1 receptors and inhibit all of these on the right arm. On the other hand, what neprilysin do is that activate the adrenergic peptide and the CNP This will lead in enhancement and vasorelaxation and in decrease in the blood pressure and in decreased sympathetic tone and also decrease in the aldosterone and the fibrosis and hypertrophy and also increased natriuresis. So inhibition by neprilysin inhibition and the blocking of the valsartan by AT1 receptors, this is the proper mechanism of this medicine. Again, ARNI significantly reduced heart failure hospitalization in all heart failure patients. We see here in the paradigm heart failure, in comparison ARNI with enalapril, in a patient with heart failure with reduced ejection fraction, they have a better outcome in the ARNI group, and in the Paragon also in a patient with heart failure with a preserved ejection fraction, it show it better in the ARNI group. And here again the slides show that ARNI reduced death from cardiovascular causes and the first hospitalization for heart failure and also improved the quality of life. In comparison, the cardiovascular mortality, the arm of ARNI is better than enalapril by 20% and the number need to treat is 32. On the other hand, the risk of heart failure, of the first heart failure hospitalization, comparison head-to-head ARNI versus enalapril is the ARNI is better than enalapril by 21%, and the number need to treat is almost 36. Here is very important slide, and before this one, I will go to the next one and then go back. We all know that heart failure and kidney are interconnected. Why? Because heart failure is associated with rapid decline in the EGFR. كنا عارفين مرضى الهارت failure يعني عندهم liability due to decreased cardiac output, decreased renal blood flow, suffering more from renal problem. On the other hand, كل مرضى اللي عندهم chronic kidney disease is also associated with incident of heart failure. سواء heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So again, in this slide, all heart failure patients ARNI reduce the risk of serious adverse renal outcome as shown in this slide and slow the decline of the EGFR irrespective of the baseline renal function. And this is very important for this medicine. Here, it's a very important slide. All of us know the pillar and the medicine for heart failure from ARNI, ACE and ARBs, beta blocker, MRA, and SGLT2 inhibitors. If you see survival, cardiovascular, and all-cause mortality, morbidity and hospitalization, quality of life, and proven reversed cardiac remodeling are shown in ARNI. On the versus, if you see the SGLT2 inhibitor, it will affect the cardiovascular and all-cause mortality and morbidity and hospitalization, quality of life, but in a proven reversed cardiac remodeling is ARNI is better, okay? What about the guidelines? The European guidelines 2021 recommended that ARNI is the first line therapy, especially in naive patients. What about the American? In 2022, American Heart Association's guideline put ARNI are the preferred first line across all over heart failure spectrum over ACE inhibitor and ARBs as shown. ARNI, patients with heart failure with reduced ejection fraction with the New York Heart Association grade 2 to 3 symptoms, the use of ARNI is recommended to reduce morbidity and mortality, and it's class 1A. And also here, shown that ARNI is a class 1 recommendations for heart failure with reduced ejection fraction with very high value, which means low cost for the patient in comparison with the hospitalizations and recurrent hospitalization and morbidity and mortality. And what about heart failure with mid-range and the heart failure with the preserved? Also shown there is a benefit from ARNI and it's class 2B in a heart failure with mid-range ejection fraction, because ejection fraction between 41 and to 49%. And what about the preserved ejection fraction heart failure, symptomatic patient with left ventricular almost more than 50%, ARNI show a benefit of a class 2B. What about the up titration? This is message for you all. احنا كنا عارفين مرضى الارني بنشوف كتير انه بضل المريض for a long time on a 50 milligram by 2. And even إذا تحسن ejection fraction still بتخلوه على 50% على 50 milligram per 2. This is wrong. We should, as we said at the beginning, it's a progressive disease. We should reach to 200 milligram twice daily. Why? Because the majority of the patient achieve and maintain the target dose for ARNI through paradigm heart failure. It's almost 76% of a patient remain at the target dose of ARNI 200 milligram twice daily at the end of this study. And here shown that sustained full dose is better, and patients who achieved and maintained the target dose of 200 milligram were more protected and has lower cardiovascular event. To conclude my talk, ARNI is the essential first choice for heart failure patient ahead in place of AC inhibitor and ARPs. Time is muscle, so we should early interfere with this medicine, and the guidelines no longer recommend stepwise treatment approach the patients with heart failure with reduced ejection fraction, but center of all 4 classes must be given all together and maximize patient outcome. But ARNI still is the only drug that addresses neprilysin pathway and also the only drug who reversed cardiac remodeling and improved the cardiovascular mortality and heart failure hospitalization. And every heart failure patient should deserve ARNI. And my last conclusion, قريبا وبإذن الله بجمعة قادمة سوف نصلي بالقدس ويعطيكم ألف عافية.
Thank you, Dr. Mohammad, for such an amazing presentation. There's always one of the challenges, as you said very eloquently and very importantly, you have to have the patient on the ARNI, preferably ARNI, and you have to uptitrate. The problem of hypotension comes to play. So what thoughts do you have to especially, as you said also, you need the 4 classes. So you need to have them on beta blockers, which reduces blood pressure, MRAs, and SGLT2s, all 3. So please tell us.
Okay, thank you, Qais. First of all of us know that every patient with heart failure must be on 4 classes: ARNI, SGLT2 inhibitors, beta blocker, and MRA. هلا احنا كنا عارفين مرضى الهارت failure is very fragile. هلا case by case we can give all the drugs, but to reach the target and to improve the heart failure for this patient, it should be on 4 classes. هلا هي tailored، يعني أنا ممكن أبلش بالآرني ب 50 ملغ by 2 مع ال SGLT2 inhibitors plus beta blockers مع متابعة الكرياتينين مع الهايبوتنشن، بس even لما يصير في reverse cardiac remodeling ويتحسن ال ejection fraction، هذا definitely it will increase and improve his blood pressure. That's why we can titrate the dose of ARNI. Okay?
Okay. Any questions?
Right.
Thanks, Mohammad. Elegant as always.
Thank you.
I apologize first. I needed to share some slides with Mohammad, but for the sake of time, I could not. We published 4 publications on Entresto in Palestinian population.
Nice.
And just a summary in 30 seconds, we showed for the first time increase in ejection fraction by 12 points. And that starts after 2 weeks of starting and initiating the drug. We followed these patients for 4 to 5 years, and the mortality, instead of being 50%, it's 29%. And to say that the patient should always be at 200 BID, yeah, that's an excellent target, but unfortunately it's unreal. So the real thing is the patient takes as much as he can, as much he tolerates and he can pay. Because before Novartis introduced that one price for any dose, the patient was paying too much if you increase the dose. And that allowed us to describe the zigzag phenomenon, which is a patient on Entresto, he run out of money, he stops Entresto, his ejection will go down, his symptoms will come back, and that will be very reproducible. So I would encourage that if you are going to give the patient Entresto, just encourage him to take any dose, because that dose will affect him positively regardless of reaching your target of 200 BID.
دكتور رائد totally agree. احنا بنحكي انه to reach 200 ملغ by 2 it's not within 1 month. بس انت بتلاحظ مجرد ما تبلش على 50 ملغ by 2 لهدول المرضى بتلاقي بعد شهرين ثلاثه بيجي لك المريض ضغطه 110 على 70 say why not, and he's stable and he's asymptomatic, but why not to push ال 50 ملغ to 100. That's why I am talking to you. It's a progressive disease. يعني احنا لاحظناه there is inertia في increasing the dose even لو كان ضغطه 100 على 70. Why not to push even لو he's stable now and he has no symptoms. Okay?
We tried over 4 to 5 years of having a heart failure team of pushing the dose to 200 BID. At the end of the study, only 12% were 200 BID. The best dose that most patients agreed upon was 100 BID.
Yes.
I agree, actually. And I find it kind of strange, you know, in the trial they said the majority were on 100 BID. But from also my, you know, Mena experience, it's very difficult to get there. You know, at most, if you're lucky, it's going to be, 50 or 20.
2 issues. The price of the medicine is a major issue. The other thing, do we have studies to prove that the low doses was effective? And what kind of a blood pressure do you as a physician tolerate in your patient? If he comes to you with a pressure of 80 over 50, is that acceptable to you?
Very nice questions. هلا الكوست first of all الكوست هلا nowadays يعني كل شركات التأمين موفريته حتى even القطاع الحكومي في المستشفيات وزارة الصحة ومستشفيات القطاع والخدمات موجود. فيعني كنا قبل نواجه مشكلة في إنه يجيبوه بس هلا صار يعني معظم المرضى حتى ياخذوا تقرير ويروحوا ياخذوه من هون ومن هون ومن هون. السكند questions هلا مريض الهارت فيلير 90 over 60 is okay unless ما في اي symptoms عنده والله فيش dyspnea فيش syncopal attack ما فيش hypotensive symptoms وكذا. وكثير مرضى عشان احنا يتحسنوا بعض الاحيان بيكون مريض very fragile وبالمستشفى وبيكون ضغطه very low we can give him a support medicine IV زي النور ادرينالين والليفو to start this medicine at the hospital. وبنلاحظ خلال weeks او 4-5 ايام لويكس انه ببلش الايجكشن فراكشن يتحسن وببلش الدواء ياخذ حتى even لو small doses of ARNI. It will benefit for him. وبعدها تلقائيا مجرد 12 weeks up to 1 month لما يبلش الكاردياك اوتبوت يتحسن والايجكشن فراكشن يتحسن رح تلاقي even the blood pressure is elevated and you can push on the dose.
I'm okay with the patient having a systolic of 75, like you said, as long as he is not symptomatic or dizzy.
I agree.
Because I think the lower the pressure,
better
the
for
easier it is.
Yes,
the afterload
definitely.
reduction, the easier it's for the heart muscle to function.
Totally agree. وهذا دائما احنا بنقوله يعني هي المشكله اللي بنواجهها انه لما يكون مريضنا معظم مرضانا الهارت فيلر 90 over 60 للاسف بيروح مثلا هون ولا هون بيروح بيقيسوا له ضغطه بيقولوا له ضغطك واطي بيحطوا له IV fluid نورمال سلاين 1000 ملغ بفوت بالمونري اديما ثاني يوم. That's why it's 90 over 60 is okay and even 80 and below unless he's asymptomatic and everything is okay.
I agree. Actually, there's one point that we should always make. You know, blood pressure is not synonymous to perfusion and cardiac output.
Agree.
Perfusion and cardiac output, there are other signs, you know, like urine output, you know, perfusion, peripherally, cold extremities and stuff. But blood pressure is one of them, but not everything. So sometimes
symptoms is very important.
Lower blood pressure for your patient with heart failure. Yes, go ahead.
I have a comment. It's not so important to know what is the systolic and the diastolic pressure to start or stop these drugs. The most important is to know the mean arterial pressure, which is between 70 and 100, 110, and which is the diastolic plus the 1/3 of the pulse pressure. 90 over 60, it's okay because 60 plus 90 minus 60, it's 30, and 1/3 is 10, so 60 plus 10, it's 70. So the important blood pressure is the mean arterial pressure, not the systolic and the diastolic. Thank you.
Totally agree, and not only this is the parameter, also to see our patients how come is the urine output, and how is the follow-up of the EGFR and the potassium. It's very important also. Okay.
All right. Any other questions from the panelists?
I would like to comment what Dr. Raed said about regarding improving the ejection fraction. Do you believe the improvement, the ejection fraction, it will continue in upgoing slope after like
Very
months
nice
or
question.
years?
It depends whether the patient is the cause of the heart failure. يعني it's ischemic, non-ischemic, whether it's peripartum cardiomyopathy. It depends on the cause of the heart failure. Some patients will improve and improve dramatically, more than 12 even, and some patients still resistant to improve even up to 5% or even 8%. Okay?
And this brings us to the point that you actually also mentioned. You know, you should never say a heart failure patient is a stable patient.
Totally agree.
You know, they used to use the wording heart failure with recovered or EF. We shouldn't use that. It's actually heart failure in remission, because the disease is still there and the requirements for the medication is still there. And
that's why Qais and I told at the beginning, the malignancy of the heart is the heart failure, and it's a progressive disease and not a simple disease.
Any other questions? Go ahead.
تفضل.
يعطيك العافية حكيم. في ضوء اللي حكوه الدكاترة في مجال بس سؤال. بغض النظر عن حالة المريض، يعني ما في رول إنه نبلش بدوزة 25 بهاي الحالة باي 2 صح؟ بأي سبب من الأسباب؟
هي الفكرة مش إنه ما فيش رول، هي إنه الدواء عبارة عن 2 بارت، فالزرتان نيبرولايسين. أنت لما تيجي تقسم الحبة مشكلة يعني، فمش إنه ما عملناهاش، لا عملناها أوت أوف ريكورد، بس إنه نص الحبة الثانية ياخذها المساء. وصلت؟ بس إنه يعني في مرضى كيس باي كيس، بعض الأحيان البلاد بريشر، الاي جي اف ار، يعني هذا شوي، بس إنه إذا أنت حتى يعني اللي بقوله دائما إنك بلش على هاف تابلت أحسن ما تبلش.
هاي هي الفكرة. شكرا شكرا حكيم.
Any other questions from panelists? We're good. Thank you, Dr. Mohammad.
شكرا يا قيس، يعطيكم العافية.
We'll welcome our next speaker, Dr. Jihad Haddad, a very well-known cardiologist in Jordan. He's going to talk about Pact, MEA, a regional perspective.
Good evening everybody. Really thank you for your introductions. أنا سعيد جدا أكون مع الزملاء ومبروك لدائما هيك المؤتمرات اللي بتصير in Jordan. So for the following 20 minutes I will be talking about the Pact MEA, the results. Pact is coming from the prevalence and in clinical management of atherosclerotic cardiovascular disease across Middle East and Africa. Now, first of all, to be a little boring and just to remind some facts about the prevalence of atherosclerotic cardiovascular disease in patients with diabetes. للأسف, we don't have many studies. One of the most really common study about the prevalence is the CAPTURE study. CAPTURE study among 13 countries showed that 1 out of 3 of all people with type 2 diabetes have already established cardiovascular disease, and 9 of 10 people with already type 2 diabetes and established cardiovascular disease have atherosclerotic cardiovascular disease, and only 20%, 2 out of 10 people with type 2 diabetes are getting glucose-lowering treatments with the proven cardiovascular disease. And we know the proven cardiovascular disease apply to the SGLT2 inhibitors and GLP agonists. So in this study really was, as published 3 years ago, showed without any doubt that we have high prevalence of atherosclerotic cardiovascular disease, but the bad news that we have really huge people without to use the proven treatments in patients with diabetes and already cardiovascular disease. Now, the unmet need that the CAPTURE study without any doubt and the others in the lectures have limited coverage of countries across the Middle East and Africa. The only really country in this RAPTURE study is Saudi Arabia and also in Turkey. The second into that, we have lack of similar representative data on atherosclerotic cardiovascular disease in the Middle East. So the purpose of Pact study was simply that really to investigate the epidemiology and the clinical management of established atherosclerotic cardiovascular disease and high, very high atherosclerotic cardiovascular disease in patients with type 2 diabetes in 7 countries in the Middle East and Africa in real-world settings. Here we can see the steering committee in these 7 countries including Jordan, but also Egypt, Emirates, Bahrain, Kuwait, Qatar, South Africa, and as I mentioned, Egypt. And also in this study, we have the Professor Verma from Canada and from Salik from really UK. Now, simply the study designed to go immediately to endpoints, the primary objective to estimate simply the prevalence of established atherosclerotic cardiovascular disease in patients with type 2 diabetes in primary care and secondary care settings across the 7 countries that I mentioned. But also the secondary objective was to estimate the proportions of patients in cardiovascular disease risk categories, especially in those with high and very high according to the European Society of Cardiology 2021 guidelines. The question is why really we decided to be the ESC and not, because the quick off was exactly 2 years ago, and as we know, maybe the new data, we have the data, it was from the ESC in practice. Now simply, very simple study, multi-centers, non-interventional, observational, cross-sectional study. The overall duration was 6 months, as simple with single visits, routine single visit, and after the consent, we really extracted the demographics, the medical history, the clinical laboratory, and the pharmacotherapy data in those patients. So the eligibility of investigators, including any physicians managing type 2 diabetes in routine clinical practice. In the really primary care, including general practitioners, family medicine physicians, including secondary care, endocrinologists, diabetologists, cardiologists. We have Dr. Iyas with us in this study also, internal medicine physicians in this study, as we know in practice. Now, the inclusion criteria for any study, it was a simple, signed, informed consent before any study, and age more than 18 years and diagnosed with type 2 diabetes more than 6 years prior to that day of signing. And other study, the exclusion criteria, including diagnosed with type 1 diabetes, mental incapacity in those patients, and sample, which is very important, no congenital heart disease or malformations. Here we can see the primary endpoints and defined as the diagnosis with any of the following, including coronary artery disease. Maybe you are the cardiologist, you know that other than us, inducing the previous acute coronary or myocardial infarctions or unstable, stable, or past coronary vascularizations, but also CV disease, peripheral arterial disease, including extracranial carotid artery disease, other peripheral arterial disease, for example, renal artery disease, and the lower extremity arterial disease in practice. Now, regarding the 6 endpoints, including patients with type 2 diabetes meeting high or very high risk criteria of SCC, as I mentioned, 2000 guidelines, including patients well-controlled short-standing diabetes, for example, less than 10 years, without target organ damage, but also high risk in patients without established atherosclerotic cardiovascular disease or target organ damage, but for example, with eGFR less than 40, with microalbuminuria, and very high risk, including patients with type 2 diabetes with established atherosclerotic cardiovascular disease or severe target organ damage in these patients. Here we can see really the proportions of patients with type 2 diabetes achieving the ESC 2021 guidelines recommended targets, including HbA1c less than 7%, LDL less 70, exercise more or equal to 3 times, 5 times per week, blood pressures less than 130/80 for all patients with diabetes, treated with cardioprotective anti-hyperglycemic therapy, including the GLP agonists, SGLT2 inhibitors, and BMI less than 25. Now here we can see the study sample. Simply, in this study we can really recruited 3,726 people with 555 sites in the care of primary care and secondary care. As you can see, in South Africa, we already included 1,000. After that, immediately we have in Jordan 576. After that, Egypt, as you can see in this study. Now, regarding the demographics and the clinical characteristics, male almost 53%, female 40-70%, mean age 58. Regarding the age group, very important that 14% under the age of 44, 58 from 45 to 64, 28% above the age of 65. The BMI 30, the median duration of diabetes 10 years, and nephropathy 25%, nephropathy 15%, neuropathy 25%, and retinopathy 14%. Here's something regarding the risk factors that we found: that dyslipidemia 92%, hypertension 71%, family history 26%, smoking 14%. The bad news in Jordan, 28% really smoker, left ventricular hypertrophy 7%, and heart failure 7%. That at least we diagnose that. Maybe in practice it will be more than that. Regarding the number of risk factors, including hypertension, dyslipidemia, smoking, obesity, only 2% without any risk factors, and more than 90% with almost 2 or 3 risk factors in practice. Now here we can see the percentage of patients on glucose-lowering therapies: 77 on metformin, 38 with insulin, DPP inhibitors 36%, GL2 36%, and GLB almost 13%. Now, what we notice that 1/3 of people with type 2 diabetes are taking SGL2 inhibitors, and only 1 in 10 are receiving GLB agonists. In Jordan, only 4%, which means in 20 really are receiving GLB agonists. Regarding statins, 77%, as you can see here in statins. In Jordan, only 6-9%. And as you can see here, that although most patients with type 2 diabetes are on statins, only about 1/3 are receiving high-intensity statins in practice that we are facing. Now, to go immediately for the primary outcome, as you can see, what we found in the study that 21% already have established atherosclerotic cardiovascular disease, which means 1 in 5 people with type 2 diabetes have already had established atherosclerotic cardiovascular disease. Now, in those patients, most patients with atherosclerotic cardiovascular disease have coronary artery disease, almost 87%, 13 or 15 with CVA, and 9% with peripheral artery disease. Now, regarding the prevalence by sex, 27% males, 16 females, which means really that more than 1/4 of males and 1 in 6 females will really have established atherosclerotic cardiovascular disease. Now, this is really what about the prevalence by country. In country, what we found that 26% with established coronary artery disease, while in Bahrain, 37%, while in Kuwait, only 19%, which means in practice 1 out of 5, in Jordan, on 4, already have established atherosclerotic cardiovascular disease. Now, the secondary endpoints, quickly just to mention what we found that regarding the proportions of patients with type 2 diabetes within each atherosclerotic cardiovascular risk category according to the guidelines, that only 1% with moderate risk. The most patients either with high or very high risk, more than 99%. Other thing, the achievement of patients in those patients, we can see in those patients with HbA1c less than 7%, only 37%, with the blood pressures good 130/80, only 3%, with, as mentioned, treated with SGL2, 37%, with LDL less than 7%, etc., etc. But only 16 with exercise, 15 with BMI less than that. So according, only 4 in 10 patients with type 2 achieves any of the risk factors, and no patients met target for all risk factors. Now, this published really, the good news published in really journals, including for diabetes, obesity, and metabolism, but also about circulations. We know the impact factors of 90, and it was really very good results to have in circulations. also was published in ACC 1 year ago, and recently also published it in the European Heart Journal about dyslipidemia. And what we noticed that the mid-list factors less than 70, only 13%, Y less than 55 in high risk, only 16%. And just to finish this study regarding the assessments in age assessment of atherosclerotic cardiovascular disease, and was presented in the ESAD recently, almost in Germany. And what we noticed that in the Arab countries and in the Middle East and in Africa, 72% under the age of 65. The other issue that even in patients under the age of 44, only 1.8 they have really risk factors or didn't have stage 1. The other issue, we noticed that only elderly subjects do use the GLP agonist, while the younger patients, they do use that. And just to maybe finish this study, that we found that 59% really on statins under the age of 44, while 84 under the age of, above the age of 65, which means in practice that our patients, they use statin only in elderly subjects, not in really younger pages. So just to conclude, as simple as that, we are talking about very nice study and the first and most comprehensive assessments of cardiovascular risk in people with type 2 diabetes from the Middle East and Africa. And this is really amazing just to talk about the most comprehensive assessment about this subject. The key endpoint showed that 1 out of 5, and in Jordan, 1 out of 4 already have established atherosclerotic cardiovascular disease in type 2 populations in those patients. The second issue, that all patients, almost 99% of patients, they have either high or very high atherosclerotic cardiovascular disease in those 7 countries, including, of course, Jordan. And the third issue, that almost 37% of patients with type 2 diabetes already in high or very high risk in CGL inhibitors, but while only 13%, in Jordan only 4%, they are on GLP agonists in practice. Thank you very much.
Thank you, Dr. Jihad. I believe we have a couple of minutes if you want to. Is there any questions? Yes, go ahead. We could have time.
So I noticed 20 minutes and thought 50 minutes. قررت 5 دقائق عشان هيك سرعت شوي.
Thank you. I mean, like you said, the average age for us starting patients on statin was around 62 years. My question about this Chinese study, that the ideal A1C was between 7 to 7.5, and that had the lowest risk of cardiovascular disease, stroke, and all cause mortality. But patients who had A1C below 6.5 or above 8 had higher incidence of stroke, cardiovascular disease. I mean, we absorbed the above 8. Any idea why those below 6.5 did as bad?
Just if I got your answer to explain why this data that we confirmed. I don't know, I don't think really exactly what happened, but the message as simple, it was with this study just to explain simply why we are in all over the world in comparison to the capture study, we are doing well to rule or to use medications in practice. So just to answer, to justify, I'm not able just to answer these questions.
Any other questions from the panelists? Thank you, Dr. Jihad.
Thank you.
Thanks. All right, so I'll welcome our next esteemed speaker, Dr. Nadim Jarrah, who's going to tell us about GLP-1 in the cardiometabolic horizon. Welcome, Dr. Nadim.
Shukran, Dr. Qais. Thank you for the introduction. It's an honor and pleasure to be with you all in this esteemed Congress. بشكر الدكتور محمود الزريق موجود والزملاء الفريق اللي معه على إقامة هذه المؤتمرات المهمة. So my talk will be over 20 minutes. I have good news for you, dear colleagues. The game has changed. Nowadays, if we treat patients up to the standard of care, حسب literature والguidelines, nowadays the game has changed. We can control glycemia, reduce cardiovascular disease risk, protect the kidneys, and reduce weight. يعني هاي الستيتمنت لو انحطت قبل 20 سنة, no one will believe me about this statement. Okay, and this was based on two historical points in the literature of type 2 diabetes. In 2015, for the first time, we had the evidence from the SGLT2 inhibitors about this benefit. And in the year after, 2016, the New England Journal of Medicine was published the data about the GLP-1 receptor agonists, showing all of these benefits in the blue box for our diabetes patients. And this is why, and this is a very good sign إنه البرنامج المؤتمر عم بتحدث كتير على two classes, ال SGLT2 inhibitors and the GLP-1 receptor agonists. These are the studies which I mentioned. We started with the SGLT2 inhibitor, بالإمباريج. It showed a clear statistical significance, followed by a leader study where the liraglutide showed again a clear statistical significance for the primary outcomes, اللي هو major adverse cardiovascular endpoints. And these are cardiovascular outcome trials اللي انطلبوا من ال US FDA بداية من 2008. For the first time in history of the diabetes literature, we had two classes which showed these benefits. It's not only to reduce hyperglycemia, مشان هيك الكلاسز هدول بلشوا يروحوا باتجاه تخصصات أخرى other than endocrinology. So nowadays we are not talking about diabetes alone. We are talking about a syndrome, سموه بالليتراتشر cardiorenal metabolic syndrome, CRM. And you can see the CRM, it can start even in the phase of pre-diabetes. ما في شيء اسمه pre-diabetes. Okay? حتى ولو blood glucose is still not that high, patients are still under the risk of having cardiovascular and renal diseases. وكل ما تقدم السكر كل ما كان CRM عندهم more advanced. So this is why we have to work very early in the pre-diabetes phase, not in the diabetes, نستنى تيصير diabetes patient. طبعا كل الجايدلاينز كل الاثوريتيز بيحكوا انه we have to treat our patients holistically. ما في شيء اسمه controlling glycemia والLDL 100. This is high. ما في شيء اسمه controlling glycemia والضغط 140 على 90. This is high. So we have to work collectively and holistically for our patients, and especially بهذا العمود is to protect the heart and the kidneys for our patients. Type 2 diabetes, their colleagues, is الباثوفيسيولوجي تبعه is so complicated. يعني لما درسنا الطب كلياتنا درسونا type 2 diabetes is insulin resistance followed by beta cell failure. Nowadays, according to this iconic slide by Ralph DeFronzo, عم نحكي عن الأومينوس أوكتيت والتركيز الشديد هلا على الانكريتنز من الانتستين والكدنيز for the SGLT2 enzyme. So most of the cardiovascular complications and death for diabetes patients comes from the cardiovascular problems, and you are the experts in this field. So we have a class اسمه GLP-1 receptor agonist, glucagon-like peptide 1 agonist. And the story started with this monster, by the way, okay, where we extracted this molecule and we worked on to produce the medications. The GLP-1 receptor agonists, they have multifactorial effects. Al pancreas, it has a dual effect, suppressing alpha cells, glucagon suppression, stimulating beta cells, insulin secretion, stimulating insulin secretion. Let alone the GI tract, the brain, okay, lipids, liver, and so on. So these are the multifactorial effects of the GLP-1 receptor agonist. So it's not anymore, it's so naive to consider it only as anti-diabetic agent. So these are the several GLP-1 receptor agonists in the market. And I will talk basically on semaglutide, which is the most popular nowadays GLP-1 receptor molecule. Yeah, of course, you know, there is some يعني تطور بهذا الموضوع. Now we are talking about the twin cretin. they are mixing the GLP-1 and the GIP in the same device and so on. So my talk will be about basically semaglutide. Yeah, and based on what I said, nowadays it's يعني متفق عليه in all societies, all authorities, west, east, wherever, that the GLP-1 should come here. I know this is very small, you cannot go through it, but ال ADA وال ASD مثلا متفقين إنه أي مريض diabetes with underlying atherosclerotic cardiovascular disease must be on a GLP-1 receptor agonist because of the huge benefit which we saw it starting with the leader اللي هي liraglutide followed by sustain 6 اللي هي semaglutide which showed the same benefit which I will show you. On the other hand, if the patient has heart failure, this patient must be on SGLT2 inhibitor and so on. This is very well known to all of you. So what's the شو اللي عمل السيماغلوتايد so unique? 3 modifications عملوهم جماعة الفارماسيوتيكال. At position 8, they substituted one enzyme to one amino acid to another, and they added a chain here, and it substituted an amino acid at the position 34. And this molecule is the GLP-1, by the way. And because of all of these, the molecule became resistant to the DPP4 enzyme, which breaks down the molecule, and it became attached to the albumin, and this is why it has a very long half-life, and this is why we give it once weekly. So this is the idea of the semaglutide, and these are the mechanism of actions. زي أي GLP-1 receptor agonist بيشتغل على pancreas, على liver, على brain, suppressing appetite, and so on. And this is, again, very well-known data to everyone. We have a wealth of data, huge data about semaglutide من خلال الSUSTAIN program, started from SUSTAIN 1 up to 11, okay? And these are the scenarios where semaglutide was used as monotherapy versus OAD on top of, or compared to other GLP-1 here, comparing to other GLP-1, adding on to SGLT2 inhibitor. Yes, we can combine the 2 classes together and so on. So this is a huge data coming from the semaglutide by the SUSTAIN program, and you can see at a glance dark blue bars اللي هي semaglutide 1 milligram اللي موجود عندنا بالماركت. If you go through across all the bars, the dark blue bar is more superior to all other agents and comparators used in these studies. Of course, these are not head-to-head studies, but the data shows this phenomenon. This is regarding the HbA1c, and this is regarding the weight. Look at the drop in the weight by using semaglutide 1 milligram compared to other GLP-1 receptor agonists, added to SGLT2, compared to OADs, and so on. So the benefit is there, and it's very clear all over the studies. And those who reach A1C less than 7 without symptoms of hypoglycemia. زمان كنا نضبط السكر على حساب هبوط السكر or weight gain, typical sulfonylurea, مش هيك؟ And this data بالSUSTAIN من 1 ل 11, it showed that there was control without hypoglycemia and weight gain. The safety, all the way it was safe in general. أي دواء له مشاكله. The main side effect is the GI symptoms طبعا, and I can show you that the symptoms usually starts in the beginning, then they will go down. However, in the real life, في ناس intolerant for the GLP-1 receptor agonist. هذا واقع, okay? But anyways, you have to encourage, and what I do, I explain to my patients. I tell them, expect to have nausea, okay? Be strong enough and try to continue so as to avoid this complication. SUSTAIN 6 مميزة. It's a cardiovascular outcome trial. مش زي السستين من 1 ل 11. SUSTAIN 6 a cardiovascular outcome trial اللي انطلبت من US FDA بال 2008 والشغل تبعهم اتطور بال 2020 and they requested all of these things to be approved by the pharmaceutical. So السستين 6 is زي ما حكينا cardiovascular outcome trial with 4 arms. One arm is semaglutide 0.5 milligram, 1 milligram compared to placebo on top of standard of care. يعني المرضى كانوا عم بيتعالجوا حسب الأصول العلمية ونضاف عليهم semaglutide 0.5 or 1 أو placebo. All right? These are the inclusion criteria. They are type 2 diabetes patients on oral medications with established cardiovascular disease. وبما انها CVO كان مطلوب منها تثبت safety على الهارت اللي هي non-inferiority. Okay? It showed more than non-inferiority actually. This is the results. It showed non-inferiority and superiority. Okay? By adding on top of standard of care. And you can see for p-value significant for non-inferiority and superiority. And the major, and the number needed to treat, by the way, which reflects the efficacy, was 45, which is a low number. لمرضى عم بياخدوا كل الstatins والaspirins and so on. Okay? This number is considered a significant number, 45 over 2 years. These are التفاصيل primary outcome. I have to skip it because for the sake of time. The systolic blood pressure للsemaglutide half one was reduced. And nephropathy. This is very amazing to have benefit على heart and the kidney. Look at the difference between semaglutide versus placebo on the new or worsening nephropathy with statistical significance. Yeah, it has benefit on the heart and the kidney.
You do have 5 more minutes on
Yeah.
top of that timer.
نعم.
You have 5 more minutes on top of that timer.
Yeah. شكرا كويس. So the summary there, colleagues, the primary outcome was approved by Sustain 6. أكرر Sustain 6 is a cardiovascular outcome trial by 26% reduction. The number needed to treat NNT was 45, which is significant. There was control of A1C and body weight. هذا الشيء ما كنا نشوفه قبل 20 سنة. Again, nephropathy was reduced by 36% in this study. And موضوع retinopathy, I will talk one sentence عليه إنه there was a signal that patients who had a very strict control للglycemia, they had some worsening of the retinopathy. بس الكدني والهارت were strongly positive. Is this reflected بالreal world؟ هل حكينا هذا كله؟ طب ما احنا مرضانا غير مش بالدراسات عايشين بعالم آخر. فالreal world evidence اللي هو صار هلا كتير مهم بالليترشر. We are talking about study اسمها SURE study in these countries. الدراسة مجرد إنه تطبيق اللي شفناه بالsustains على الريال لايف was their benefit and the result yes, the change in HbA1c was reduced in these countries موجودين كندا وكذا كذا. These are the countries. It was reduced and there was reduction in the body weight, which is reflecting real life sustains results. This slide was interesting to me. And the most common reasons to initiate once weekly semaglutide. شو كان السبب؟ هل إنه هذا عشان المريض عنده AS cardiovascular disease? No. It was in these countries اللي هو to improve glycemia control and to benefit the weight reduction followed by addressing the cardiovascular disease. اللي هو اللي صاير عنا بمجتمعنا. Okay, الناس عم تركض وراء GLP-1s as weight lowering agent. Okay, but we should remember the huge benefit على الهارت and the kidney and the weight. أنا مش يعني معارض هذا الإشي. Yes, so dear Mr. Chairperson, dear colleagues, the SURE study in these countries in the real world setting showed at GP sites showed يعني البنفيت على glycemia, على weight, and so on. I will not go through it. The overall summary. Semaglutide provided consistent glycemia improvement in sustains من 1 ل 11 including 6. Semaglutide resulted in significant weight reduction وهي مش هحكي عليها كتير عشان عم نشوفها عرض الواقع. In sustain 6 alone, semaglutide significantly reduced overall risk of MACE with a 26% risk reduction versus placebo on top of standard of care. Semaglutide was well tolerated in both sustained RCTs and the SURE study. GI side effects is an issue, and we have to take care of it. And with this, thank you for your attention.
Thank you. Yes, amazing. Thank you so much. Thank you for such a great presentation. A quick question, in the realm of, in perfect world, you have access to all these medicines, you have money, you can get them, you optimize your patient. Now, let's say true world, you don't have that much, you have limited budget, and you have a patient who has a CRM, or an advanced, high risk profile. Which one are you going to choose, SGL2 or GLP-1?
Thank you for the
Tough
question.
I'm sorry about that.
هلا 2 points. إذا بدي أمشي على الكتب، إذا المريض معه predominantly heart failure, SGL2 inhibitor. No heart failure, obese, I will try to convince him or her to take GLP-1 receptor agonist. And don't forget, we can combine both, by the way, with a huge benefit. بالreal life عم نشوف فوائد مذهلة when they are combined together.
Just that to remind ourselves, I'm against this answer, Doctor, sorry. In the heart failure with a preserved ejection fraction, the only indication is for SGL2 inhibitor. It is a class 1 indication. But if we say that there are some study for the patient with HFpEF, like STEP trial, there is some beneficial effect of semaglutide for the weight reduction, symptomatic improvement, and not improving survival. The only thing, the only medication which improves survival in HFpEF is the SGL2 inhibitor, not ARNI, not diuretics, only the SGL2. This is the guideline, the recent guideline. But there are ongoing trials, as you mentioned, they are encouraging to use the semaglutide in those with overweight and heart failure, because exactly because that the SGL2 play a very important role in HFpEF, because it is now has been classified, it is an inflammatory condition like vasculitis and so on. But till now there is no it is a class 2B. We can use the semaglutide in heart failure and preserved ejection fraction.
We are on the same page. يعني مريض عنده heart failure must be on SGL2 inhibitor.
Yes.
الauthorities كلها والsocieties ما غيروا، حاطين البوكس تبع ASCVD والheart failure, and that's it.
True. The question was, what about high risk profile patient? Not heart failure patient, like a CRM patient. Should you go
CRM,
for SGL2 or GLP-1?
It is the same thing. Those are the high risk. Also, they are classified with heart failure and preserved ejection fraction.
I got you.
Yes, that's the point.
I see what you're saying. Okay. Good point. Yes, go ahead, please.
Thanks, Dr. Nadim, for sharing this bulk of information with us. If cost is not an issue, which it is an issue, but if we assume it is not an issue, why not all patients, pre-diabetes and diabetes, regardless of their hemoglobin A1C, be on one of those, taking glucophage out of the equation? Is there a problem with this approach?
To remove metformin?
Metformin out of the equation and be either on GLP-1 or SGLT2 in any patient with diabetes or pre-diabetes?
Yeah. If we have the luxury to give GLP-1, many of our type 2 diabetes patients will be on GLP-1 receptor agonist. هلا قصة الميتفورمين اللي طلع فيها الكارديولوجيست حضراتكم بال 2019 اوكي لما نزلوا الجايد لاين, and this was not happy, ال ADA were not happy with this, انه نزل الجايد لاين اللي هو very well known name, شو كان اسمه الاوثر, المهم نزلوا الجايد لاين انه مش شرط تبلش بالميتفورمين اذا المريض عنده diabetes و heart issue, start with SGLT2 or GLP-1 receptor agonist. احنا بعدنا يعني having the old school او the let us say the safe school by keeping metformin.
But there is no harm. Is there any harm of any patient with pre-diabetes you start SGLT2 inhibitor or GLP-1 based on their weight?
Pre-diabetes?
Pre-diabetes.
هلا pre-diabetes ما عندنا in our literature انه نبلشهم على هدول.
Is there a harm?
But off label we are using them.
Okay.
Yes, sir.
Go ahead.
and reduce the LV hypertrophy. I mean, I want to use the chance that you're here and you're the master to ask you about, we know we have a pandemic of obesity, we're having a pandemic of diabetes and pre-diabetes. Where do you see us going with the Wegovy, the Ozempic, Mounjaro, and the new generations? Because I think a lot of what we're seeing is a consequence of overweight and obesity and all that stuff.
This is a $1 million question or $1 million question زي ما بيحكوها. اللي تفضل فيه الزميل هنا منعكس بسوء الاستخدام والهاب هازارد يوز اوف ذا كلاس كلياته. هلا مش معقول كل واحد اوبيز بده ينحط على GLP-1 receptor agonist. On the other hand you have a tool وممكن تفيدوا فيه. فإتس a matter of wisdom and you know connecting مع المريض مع أهل المريض مع ال affordability and so on.
Any questions from the colleague? Thank you so much. Appreciate it.
عفوا.
Thank you. All right, so moving to the last lecture, but not least in the session, is Advanced Cardiac Imaging, Cardiac Magnetic Resonance by Dr. Ahmad Elayan from DAY2, and very important modality coming up and becoming more and more important. Please go ahead.
Thank you, Mr. Chairman. Thank you, Mr. President. Our presentation today will be Advanced Cardiac Imaging, Cardiac Magnetic Resonance, CMR. The outline of our presentation will be technical advantage of CMR over other imaging modality, why CMR is the gold standard for volume function assessment, meaning of tissue characterization by CMR, and we will have also some short cases review. So first of all, the technical advantage of CMR, we are not using ionizing radiation. There is no radiation in MRI. We can obtain imaging at any desired orientation without moving the patients. We have no acoustic window limitation. It's a window independent. It also has a high spatial resolution, high temporal resolution with excellent signal to noise ratio. And now CMR is the gold standard for volume and ejection fraction. Why is that? Because we are able to slice the heart into multiple slices in short axis. We can able to measure the volume in both in diastole, in systole, and even in phases in between. And by the assistance of new tools of segmentation, we can able to measure the ejection fraction accurately, and it's operator independent. So if you can do a scan in Jordan, and if you measure the ejection fraction outside Jordan, you might have the same results. This technique does not need any type of contrast injection. It's only take 5 to 7 minutes. CMR also non-invasive technique. It's able to identify, localize, assist myocardial fibrosis. The high spatial machine with 2 millimeter resolution compared with 10 millimeter resolution for like SPECT, it's able to identify even small focus of fibrosis. About tissue characterization, MRI have a very important tool in characterizations of tissue, like the famous late gadolinium enhancement, novel mapping sequences T1 and T2, and these techniques used to assess myocardial fibrosis, edema, and infiltrative cardiomyopathy. And when we talk about mapping, mapping can be used in both quantitative assessment and qualitative assessment. Qualitative, that, as you can see, this color map, it's a qualitative assessment for the myocardium. Every tissue will have coded with normal color, with color. If it's normal, the color will be uniform. If it's abnormal, like in this case, we have the green for normal and blue for abnormal. This is the qualitative assessment of mapping. And also we have the STEER imaging, short tau inversion recovery, and T2 mapping to evaluate myocardial edema. Also the famous late gadolinium enhancement and pattern of enhancement, and as they say, the bright is bad. In cardiac imaging, when you do the late gadolinium enhancement, any bright spot in the myocardium indicating that there's a bad condition occur. There is different pattern of late gadolinium enhancement. It can be ischemic, it can be non-ischemic, like if you see the subendocardial enhancement or transmural enhancement for ischemic pattern, or mesocardial or midcardial, diffuse pattern, or epicardial, like in myocarditis. There are different patterns for different disease, and it can be clearly demonstrated through late gadolinium enhancement. I will go through immediately 2 cases, and before discuss the pathology case, we need to review the normal one. This is a cine imaging, steady state free precision sequence, the movie that we use to evaluate the heart motion. There is no wall motion abnormality. If we have closer look to this image, this is the end diastole, left 2 chamber, 4 chamber view and 3 chamber view, and the end systolic one, and the late gadolinium enhancement. And I need you to have a look to the myocardium. The myocardium or late gadolinium enhancement need to be black as much as we can. Moving another slide to mapping sequences. Mapping sequences, I said before, it can be qualitative and quantitative assessment. This is the quantitative assessment of myocardial tissue. We can able to measure the T1 relaxation and T2 relaxation at different cardiac segments. And I need you to memorize these numbers. This T1 relaxation, it's a number between 977 to 1050, while the T2 mapping, it's a number between 55 to 57. Our first pathology, hypertrophic obstructive cardiomyopathy. CMR can help us to locate, extent, and measure the thickness of myocardium. Not only the thickness of myocardium in patients of hypertrophic obstructive cardiomyopathy, but also the myocardial fibrosis, if present, or late gadolinium enhancement. We can see the hyperintense signal in short axis image here and here, indicating myocardial fibrosis. And we can see that MRI provides us also a simple way to measure the thickness at different slice position. It can be at basal, mid, or apical, and also it will help us to measure the flow. As we can see, this is a 3-chamber view. In plane, flow, we can see the black hole in the middle of the scan. This scan was done with sampling velocity 2.5 meters per second. The black hole here represents a lasing artifact. It tells us that the velocity or the speed of blood at that level is higher than 2.5 meters per second. So when we increasing the sampling velocity to 3 meters per second, there a lasing artifact or the black hole is no longer existed. And by applying the simplified Bernoulli equation, which is 4 times velocity squared, the estimated gradient will be 36. This is another patient who has been followed up for 8 years, since 2003 to 2011. It's not only the thickness is important to follow up your patient during the years, but also the fibrosis. We can see that the fibrosis became more progressive. It's bigger in size and more hyperintense. That indicates the progressive myocardial fibrosis formation. Now, dilated cardiomyopathy. 4-chamber view, cine imaging, showing wall motion abnormality with transmural enhancement. We can see, as we said before, the bright is bad. Transmural enhancement, it takes around 50% of basal segments, and the better of enhancement is ischemic because of transmural better of enhancement. Amyloidosis, diagnosis of amyloidosis, it's a quite bit challenging in MR and other techniques. Remember that we said we need the myocardium to be as much black as we could. If you look at this TI scout or look-at-looker technique, at some point you will find the myocardium is black. But in patients with amyloidosis, we are unable to null the myocardial signal. So that's because the infiltration of amyloid through the myocardium. But in normal patients, we're able to null the myocardial signal. And this is the first criteria to diagnose patients with amyloidosis. This patient was proven to have renal amyloidosis by biopsy. This large lymph node here, and if you can look to the heart, the dirty signal, I don't know if you can able to see the white spot diffusely pattern in the myocardium. And Another important thing is the mapping sequences. The mapping sequences play important role diagnosis of amyloidosis. There is increase in T2 value. It's around 60 millisecond. But if we look to native T1 mapping, it's around 1,300 or 1,200. And the normal value was 950 to 1,000. We can also do the mapping sequences after contrast media. We have seen that the value of mapping sequences after contrast decreased a lot. It's 277. That indicates the myocardium is unable to wash out the contrast. And if we use this equation by measuring the T1 of myocardium post-contrast minus pre-contrast divided to the blood pool, post-contrast minus 1 contrast, and added hematocrit to the equation, we will be able to measure the extracellular volume, and in this case, it was increasing by 45%. And this is another proof that this patient might have amyloidosis. Another case, endomyocardial fibrosis. This patient was severely ill. We can see the pleural effusion, mitral valve regurg, and tricuspid regurg. This is the calcification by CT scan, the ascites, the irregular liver border, and the diffuse pattern of enhancement, subendocardial enhancement for both RV and LV. This is picture of endomyocardial fibrosis. And if you have, this is the axial section through the patient. We can see now the regurg. Viability. This is the cine imaging. There is wall motion abnormality. There is enhancement along the LED and RCA territory, indicating non-viable myocardium at this part, if you can see the enhancement, and in short axis images also. Another case of viability, the ejection fraction was 25%, wall motion abnormality again, and there's a viable myocardium along the RCA and LCX territory, but non-viable tissue along the LED territory, and there is small thrombus or apical thrombus presented here. We can see how the enhancement at LED territory from viable tissue. Our last case, subaortic membrane. This is a 32-year-old male patient presented with significant alveolar obstructions. The estimated gradient was 64 because the velocity at the level of alveoli was 4 meters per second. This is the subaortic membrane. There are thickening in tricuspid valve, aortic valve, and there is aortic valve regurg. It was around 27%. The Elayan artifact was present at velocity 3 meters per second, and there were no evidence of myocardial fibrosis. This is the reconstructions of coronary artery along, this is the LED, and the RCA and MRI can be used to evaluate the origin of coronary artery if there's any anomalous origin. And this is how we know that the velocity was 4 meters per second. At 3 meters per second, there's a Elayan artifact. No Elayan artifact at 4 meters per second. By, again, applying simplified Bernoulli equation, the estimated gradient was 64. Take-home messages, cardiac MRI is a comprehensive one-stop shop modality that help in managing the risk stratification and has unique capability to assess cardiac function, tissue characterization, detection and determination, pattern of enhancement, planning for ablation and device management, discover, diagnose hidden or unexplained symptoms. Thank you very much for your listening.
Thank you. I have a few questions, but I'm going to open the floor for any other questions from the panelists.
Thank you very much, Dr. Ahmad. Actually, one of the brilliant talk in this conference.
Thank you very much.
Actually, we are a good progression in the field of cardiology and advancement. So we should be parallel at the same time in the imaging in the cardiology. There is a very, very, very big challenges we face. You cover and put a very important highlights on the using of the cardiac MRI, the diagnosis of the amyloidosis, a diagnosis of the RV dysplasia, the myocardial, and so on. But also we have an advancement in the LVAD also. There is a big rule in using the and follow-up of those patients with LVAD. For example, in our center, we are starting to use LVAD, heart meter 3. Till now, and this year, we implanted more than 10 of LVAD. So those patients with LVAD, they need a follow-up. One of the best tools to follow up those patients is to use the cardiac MRI. You should you cover the subject in a perfect way, and that's one of the important thing to put is that some centers using LVAD, there is a big rule for the cardiac MRI. Do you agree with me for this?
Yes, sure. We scanned our patients since 3 years for now. A lot of patients benefit from cardiac MRI. A lot of disease was diagnosed. Even the congenital abnormality, following up your patient, okay, with abnormality myocarditis, patient, especially post-COVID era. Definitely MRI and imaging, I think they should work parallel with cardiology in both CT scan and MRI.
Thank you.
Yes, go ahead, Doctor. Yes.
Thank you for the nice talk. Any place that this can be helpful in coronary disease patient with AFib who cannot go into like CT angiogram because of high creatinine? Can MRI give you information about the coronary tree?
Not really. It can give you an idea about the origin of coronary artery, but the flow, no. Now, even patients with high creatinine and suffering from coronary artery disease, you can only say if there is a viable tissue along that territory or non-viable tissue along that territory. But the contrast and for patient who has suffering from kidney function disease, we can scan patient even if the eGFR is higher than 30, not like CT scan.
Dr. Ahmad, isn't there an MRI perfusion scan, which is similar to SPECT?
Yes, sure.
So you can diagnose coronary artery disease through that way. Maybe that's what Dr. Diaz was alluding.
He asked me if I can say there's a lesion in the coronary artery and what is the stenosis ratio, right? No, we cannot do it.
No, so yeah, seeing the exact artery you can't, but you can see the perfusion.
Perfusion and the feeding area, if there's fibrosis along that territory or not. Yes.
Go ahead.
Thanks, Ahmad. My question is two facets. One, what's the absolute contraindication for a cardiac patient to go to MRI? Do you have something that you will say your patient will not get any benefit here, whether it is related to metals, related to AICD, or related to anything? That's number one. And number two, what's your role in constrictive pericarditis with myocardial tagging that you do? I don't know if you do or not. Thank you.
Now we are not, I will ask the second questions at first. We are not using myocardial tagging. Tagging is old-fashioned now. You can use the mapping sequences with late gadolinium enhancement, and you can do the evaluation fully without using the tagging. For your first questions, the main contraindication is the implanted device in patient. Some patients come with material that is not safe in MRI room. And now, even with ICD, some of ICD now compatible with MRI. You can do MRI mode on and do the scanning. And we have 3 to 4 patients last year with ICD. The main challenge was how it's near to the heart. If it's close to the heart, there is a lot of artifact. The cardiac MRI is not good in that case. But if the ICD is not MRI conditional, no, you cannot scan your patients. And some patients with hypersensitivity to contrast media, you can do cardiac MRI with mapping without administration of contrast media. There is these are the two main reasons why we do not do cardiac MRI.
My questions were about the congenital heart disease. You mentioned, we can check the volumes, check even QPQS, and also, do we have that in Jordan?
Yes.
It's available.
Yes. We can do pediatric with congenital heart disease, actually corrected one. Okay. All the patients came to me after correction.
With shunt calculation?
Yes.
With shunt calculation with hemodynamics?
Yes, sure. evaluation of patients with congenital heart disease should be done by measuring the flow at the level of aorta, ascending aorta, main pulmonary artery, right and left pulmonary artery, and to see teratology of halute, transposition. Even in the booth, I have case with a transposition of great vessels. The patient is now 20 years old, but he is now very fine, and I have images on screen now. Yes.
My question for nice talk actually, and this is very interesting topic. I'm here.
Dr. Raed.
Habibi, Allah يعطيك الصحة والعافية. My question is really about the ischemic cardiomyopathy, and I'm interested about checking the viability and the reversible ischemia. What measures that you utilize to differentiate between a viable area from reversible ischemia from the normal area, as we say, and which area when you open the vessel that will gain benefit, and how much benefit can we get from that? I know that the parameters in MRI is completely different than the nuclear scan, so please can you clarify the most important three major criteria?
Sure. Now, in patients who are suffering from coronary artery disease and there is a blockage in the coronary artery, some will say, is it benefit to open that vessel or not? After, do the imaging, and if you find a viable tissue along that territory, definitely revascularization will improve the patient's condition. But there's a study prove that, but non-viable tissue, even if you do the revascularizations, the outcome will not as
no, this is my answer. That's why I want to refer the patient to you to find, before I open the vessel, to open it or not to open it. So what you will do for me from the MRI, what answers you will give me? Okay, I'll go ahead and open it.
Well, I will give you the answer about the viable tissue only.
Thank you.
Yes.
What criteria you will use there by the MRI? Because the MRI now, you want to see that if it is viable or not. You may use the help of gadolinium, but also we need from MRI to give us about the regional improvement. Regional improvement for that area of the totally occluded vessel, which is a blocked vessel. I want to find out that area will get benefit after opening this vessel. So I refer the patient to you, and what I expect from you to tell me, yes, this area is going to get viable. For example, to give me an answer, yes, there is a viability of more than 10% in that vessel.
Yeah, that's
in that area of that territory of that vessel, you will answer me about the thickness, yes, if there is thickness. The third criteria about the volume that you will get improved, and the velocity. I think all of these criteria now, we are depending it, because now, for CTO now, it's very important actually to find out which vessel to open, which vessel not to open. And we are depending nowadays in 2024 in the MRI more than any investigation, any other investigation. So what are the important points that you will tell me, if this area has this and this and this, I will know that to open this vessel or not.
Most importantly, in cardiac MRI report for you to read is the viability, how maximum, how the thickness of myocardium, the thickness of viable tissue, and the thickness of non-viable tissue. If there is completely non-viable tissue at that area, it's no benefit of revascularization. But if you have remain thickness of myocardium, you might benefit. That's my answer. I don't know
isn't there a percentage? I believe there's a percentage. There's a percentage.
Percentage, yes,
which is
25% of thickness fibrosis,
I think
50% of.
Dr. Raed,
not to embarrass you.
Dr. Raed, you mean what are the signs of the viability
we have
during
MRI? Now the MRI, that's why when I refer a patient for this kind of for CTO and for cardiac MRI, I want to have an answers for that regional area. How much would gain benefit after opening this vessel, to open it or not to open it from the beginning? And nowadays we have criteria depending not only on the thickness and the viability, and for the regional improvement. I think we will review together these things, and maybe to sit and tell you exactly what are the points. Thank you.
Sure. Thank you very much.
Dr. Raed, can I interfere with this point? Actually, it is the pattern of the delayed enhancement with the gadolinium, which will affect
بس الصوت شوي. الصوت عدلوا لها الصوت صبايا.
It's actually the pattern of gadolinium enhancement and the distribution of the gadolinium in the myocardium. So you will see that it is in the submyocardium, myocardium, and the distribution, it is septal, posterior, anterior. And this, as Ahmad shown one of the images, there was a delayed enhancement in part of the heart, which shows that this is a viable tissue. And there is a part on the apex of the heart which was not enhancing, and this gives you an answer that this is a not viable tissue. So this gives you the distribution of the artery, which part to revascularize and which part not to revascularize.
This is the old way of getting the benefit from MRI. Now in 2024, for the last 2 years, we have many advances actually in MRI, how to assess an ischemic area. Ischemic area, I need 2 answers now from MRI, and this is what's done outside. I don't know if we can do it in Jordan. I'll be so happy if we have it. 2 things to differentiate, not only viability and also reversible ischemia by MRI. It is not only gadolinium.
So, yeah, for the sake of time, we'll take just one more question. Thank you.
My question, thank you for this lecture first. Is it superior MRI for viability or the standard technician nuclear medicine for viability more superior?
Now I think MRI is superior than any other imaging modality now. Yeah, it's safe. There is no radiation. You don't need to inject your patients with Dr. Qaisi.
I always disagree with this. We have a toolbox. Each one has advantage and disadvantage, yes. And we use it according to our patient. Yes. We don't want to say one modality is better than the other. They're all good.
Maybe because
we're lucky to have them all.
So I'm a little affinity to MRI, yes.
Dr. Ahmad.
Has small comment.
Yes, go
ahead. Ahmad, I need to refer to you in the ischemic cardiomyopathy major trial from the UK, where they send patients for bypass with ischemic cardiomyopathy, depending on MRI viability study, actually did not pan out. It did not reflect, even in the UK. If you predict viability, it's not always the case. So we need more data than what's available.
More data about fibrosis.
Yes, especially, yes, exactly right. Thank you so much.
Dr. Qais, just last comment. Do you introduce AI in your MRI or not?
No, still AI, it's a research field. No, using an AI.
So we brought now our MRI from China, with AI. It is the last version.
No, I'm an AI specialist, by the way, okay?
Yes.
My thesis was pure AI in cardiac segmentation, but I believe now we are far, far, far away from applying AI fully in medicine.
I think they will solve that. What I give an answer to Raed. What are the viability and reversibility? So we hope in the future we get it.
That. If you feed your software with enough data of viable and non-viable tissue, the AI will able to distinguish very easy. By the way, it's a simple code.
Thank you.
Any expert one can write the code in 3 days.
Thank you very much.
Thank you so much.
Thank you
everyone. We'll move for the next session.
احنا معنا حوالي 20 minutes. We'll come back. ممكن ناخذ break and we'll come back نكمل ال presentations والsessions اللي جاية. يلا يعطيكم العافية.